So today we're going to do a shave biopsy. So if we can just look at the tray, you have a 15 blade, and of course this is on a handle. Alternatively, you can use we call it a bendy blade, and it's an American Safety Razor company, and it comes as two razors in one, and so basically you have to break it off, and this is actually inherently not particularly safe to do, but if you just fold the thing in half in the paper, you hear a snap, and then now you have two items here to work with, okay? And the way a bendy blade would work is you just hold it in your hands this way, you see that? And then you can shave, okay? Anesthesia, alcohol, gauze. So we clean the area and
anesthetize the lesion intradermally, raising a bleb.
So, hold on, I'm pulling this back, pinch, raise the bleb. And I suspect this lesion to be just a seborrheic keratosis. The patient is complaining that it bothers him, so we're going to take it off. Okay, so we've raised the bleb. Okay.
Use as few needle sticks as possible. Interestingly, the areas that continue to bleed after aluminum chloride is applied are the places punctured by the needle made when anesthetizing.
So yeah, so sometimes you shave the thing off, you stop the bleeding with aluminum chloride, which by the way is on the tray, off the tray deliberately, and there's still pinpoints of bleeding, and that's from the needle piercing the skin. But okay, go ahead.
The nature of the lesion and how it sits in the skin will dictate the technique to use. One method is to pinch the skin under the lesion so that the lesion rests at the apex of a taut bulge.
Okay, so, here, it's on a surface that doesn't have too much skin laxity, so, but you could pinch this lesion up and shave it off, okay? In this case, I'm really not going to do that, okay?
The lesion can be cut through along its base. The problem with this method is that you get more tissue centrally than at the sides.
Yeah, so you see, like if I cut here, the initial part is flat, and then as I go across, I'm getting like a ton more tissue, and then as I come out the other end, a little more tissue. So if I cut clear across, the biopsy is actually going to look like, I don't know, convex on the base of it. Okay?
And the resulting defect, once you release the pinched skin, is a divot.
You'll have a concave thing in corresponding to the piece of skin that got out. Okay.
Rather than a flat lesion. However, sometimes it is useful to use the pinch technique to make just an initial slight incision in the skin. Another method for starting the shave is to pull the skin back with the left thumb, holding the blade in the right index thumb and holding the flat part of the blade at a 30 to 60 degree angle to the skin.
So, and this is the technique we're going to use. So basically, you'd want to initially shave flat, right? But you can't quite get in here. So first of all, I'm holding the blade like a pencil, yes? Okay? And this is my right thumb and index, and I'm able to hold like a pencil. But notice I angle the blade more at a 45 degree angle. I'm going to make a slice. That allows me entry into the skin. Then as I'm going to cut across, you're going to always see the tip of the needle here, the tip of the blade here. I'm never going to let the tip of the blade disappear under the skin, because then I don't know how deep I'm cutting. So I always want the tip of the blade to be visible, as well as the proximal part of the blade, and anything in between is the lesion is going to get cut out. I also don't want to make too much of a sawing motion, because you're going to get jagged edges. So you want to try to start here and just slice in one direction, or push, or make very micro slices, but not gross slices. Okay?
Make a slight incision at the base of the lesion to be shaved.
Okay, so now I'm gonna basically put tension opposite to where I'm cutting. So I'm gonna make a small slit. Okay?
The left thumb pulls the skin in the opposite direction of the blade movement.
So, I mean, here I describe it like that, but so long as there's something opposite, and here it's my index finger pulling opposite. Okay?
If you don't make the initial slit, sometimes the blade does not penetrate the skin, and the lesion bunches up at the blade's edge without being cut. Once the skin gives, the shave turns out sloppy. Now,
yeah, so if I'm going to do it this way without the blade part of it, if I push and it doesn't give, you see the lesion is bunching up, eventually it's gonna all cut and everything's gonna like give, and you're gonna have a sloppy cut. You want to be in control with the whole shave, okay?
Now, the blade has the entry point of the slit. Cut through the base of the lesion, now entering with the blade parallel to the skin.
Okay, so here I am initially just getting this initial set. Now notice the tip of the blade is not under the skin here, right? You have to look very carefully there. Do you have it?
Mm-hmm.
Okay, and I'm trying to take only the lesion and not more than the lesion, and so it's taking a little more time than normal, okay? So I'm angling here a little bit. The idea is eventually, and here I may have to indeed pinch here. See, this makes it a little easier. Okay, go ahead.
Do not saw back and forth.
So here now, notice I got my slit, and now I angle the blade parallel, because now I'm ready to go parallel. And as I'm going parallel, so I'm trying not to saw back and forth. I'm doing little micro saws, but I'm mostly going in one direction, and I'm still always exposing the point of the blade. I never go under, because now I don't know where I am. Okay, go ahead.
If possible, start with the base of the blade away from you, and while putting pressure perpendicular to the movement of the blade, pull the blade toward you. Never pull the blade so much through the lesion that the tip is lost under the lesion.
Like that, that's bad. Okay.
You should always keep the tip visible and above the skin adjacent to the lesion.
Okay.
Be sure to get sufficient depth for histologic analysis.
Okay, so here you see that I have the sufficient depth. The most common problem is to go too superficially, as we're going to mention again in a second. And so then you're not, but here I see dermis. I don't see fat. I don't need to see fat, but I see dermis, and I see that I've gotten the whole lesion. Okay?
A common novice error is to take too superficial a shave biopsy, yielding a suboptimal specimen. On the flip side, going all the way to fat defeats the purpose of the shave, as this may require a suture.
Now I'm deliberately pausing here. Normally I just and it's done. But okay.
To do this, if you see that you are too superficial, angle the blade at 30 degrees until the midpoint of the lesion.
Yeah, okay, so you see, let's say I started out too superficial and I had to correct. So instead of maintaining my I don't want to cut myself there. So instead of maintaining the parallel thing, I would angle down again and get a deeper portion. And for example, if I don't care about the cosmetic outcome because I think it's a cancer and I didn't get deep enough, I can always do that in the middle and then kind of come up again. Okay?
Then angle it parallel or even upwards 10 to 30 degrees as you exit the opposite ends of the lesion from where you began the incision.
Okay, so here you see I'm angled slightly downward or parallel, and at a certain point I am going to, realize that I'm done and I want to angle upward. You see I'm angling upward? Okay, and normally you have forceps to grab this lesion, so that's too bad that we don't have any. Or you can just hold the lesion flat like that and just, it should just come off there. Shame on me. Of course, while we're filming, it's not going to work, but that's okay.
Always make sure you see the tip of the blade beyond the lesion and over the adjacent skin. That prevents unintended cutting of a larger area and allows you to control the depth of the shave.
And now I'm just going to put this thing in the biopsy bottle. Okay.
Often one swipe with the blade will not suffice, so a return of the base of the blade to its original position away from you but further along the perpendicular axis is required. Again, drag the blade toward you and finish the shape.
Okay, so the idea is and we're just going to do this again. You make the slit, and let's say I go like this, right? And I didn't get all the way through the lesion, so now I have to go back, like carriage return on a typewriter. Does anyone remember that? And then you go and do it again, okay? Or do little micro cuts. There's many different ways of doing that. Okay.
If using a bendy blade,
Yeah.
hold the blade between your right thumb index. Bend the blade so it is in the shape of a U. The initial incision is easier in this case. Simply make micro saws back and forth such that the apex of the U is always parallel to the skin. The apex can be angled downward to get more depth or upwards to get less depth. As you get to the ends of the shave where it is hanging on by just the opposite ends of the epidermis from where you made the initial slit, you will need forceps to grasp the specimen.
Yeah, I blew that. Okay.
Do not pull the specimen upward such that it is perpendicular it is perpendicular to the skin. Rather, pull it parallel to the skin away from the now pedunculated base of the
So
specimen.
you saw what I did initially, imagining that this piece of alcohol or the lesion, I cut it and it's hanging off. Now some people would want to do this, pull it up and cut it that way, and I'm saying what I did is hold it, with a forceps ideally, but let's say this was my forceps, you hold it parallel to the blade and opposite to the blade, so that you're basically, again, pulling in this direction while cutting in that direction. So you're pulling that way and cutting that way. You always want to do that, and not while it's perpendicular, but while it's parallel to the skin. So you're pulling it like that. Okay?
Swipe the blade through the pedunculated portion, thereby freeing the specimen. Do not try to stabilize the specimen with your gloved finger. Just get the forceps and use them.
Yes. Okay, so I didn't have the forceps. Okay?
Some people try to do the procedure without forceps, treacherously in a variety of ways.
Okay?
Put their finger or thumb pad at the base of the pedunculated attachment and press the blade toward their finger. The thought is that they can feel the give of the skin when the lesion completely detaches, but not go through their glove. The result is a laceration, as it is not so easy to judge that by feel.
And now I'm just going to take the aluminum chloride here and just roll it along. Basically, you saw that pressure stops the bleeding at this point, but if you're in a hurry, aluminum chloride also stops the bleeding. Okay. Anything else?
Oh, there's a B.
Well, go ahead, just read it.
Alright. Put their finger over the lesion in its original position before it was cut. Then they saw off the pedunculated area. The problem is that you can't visualize where you are sawing, and the specimen sometimes slips away under your finger as the blade drags it along because the pedunculated portion did not cut. The tendency then is to attempt to grasp the lesion with the index thumb. It will slip. Then, in frustration, they put their finger at the base of the attachment, moving the blade toward their finger.
Yeah, right. So, okay, initially you think that like the flop is over the blade, right? But there's still this pedunculated portion. So you say, oh, I'll just put my thumb here and do that. But then sometimes it slips, and I think it did on the video. And so then you kind of are like, all right, well, I'll put my thing here and not cut myself. But you just use a forceps, and you avoid all of these problems.
Hemostasis?
No, I think we're done. Okay.